You are watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. Today's topic, new treatment options for people with back pain. And we're talking about electronic stimulation to avoid, and for many people that don't have to have drug therapy. With us, we have an expert on the topic. We've had him on the program before, Dr. Roland Reinhart. Dr. Reinhart, welcome to the program.
Well, thanks for having me.
Now, good. So, big topic today about all the new stuff for people with back problems. But first, for people that don't know your practice,
Right.
Who's a typical patient? What are the different services you offer?
You know, we treat basically the full gamut of pain, from migraine headaches to aches and pains, orthopedic injuries, and cancer pain as well. So really, if you've got pain, you know, we're the people who can help you.
So in your practice, what are the different modalities, I guess, you're using to help people with pain?
Right. So, well, we're treating a wide spectrum of patients, golfers, tennis players, just anybody with activity that may have back pain. People that in particular may be trying to avoid surgery, may be trying to avoid having more interventional type things done. So we'll do, a number of conservative treatments, and then we also can go on to
conservative, like what? Epidurals?
Epidurals or medication management, physical therapy. But epidurals, they've been around for a long time. They're about 75% effective, but in many cases, that may only last for a short period of time. So what's really revolutionized things in the last few years have been advances in use of electrical stimulation to help control pain, which, there's been a huge concern about the opioid epidemic and people using narcotics. And so,
are there people that you've taken off medications, or they're off their medications just using this electronic stimulator?
Absolutely,
Really?
absolutely. In fact, the data would show that there's about a 68% reduction in narcotic use, and that actually holds up over 2 to 5 years. So you actually can get their medications down. Depends on, again, what's wrong with the patient, but in the appropriate patient, if they're taking it for pain-limited areas like, sciatica or down their arm related to their activities, these kind of stimulators can be very effective at eliminating their pain.
Now, people need to know. You've been in the desert now, practicing pain management for how many years?
Since 1991, so 25, 26 years.
26 years. Yeah. And I met you about 18 years ago. You were on the show. You were kind of doing, I think you were doing stimulators back then. So tell me a little bit about the evolution of these electronic stimulators.
Right. So about 2 years ago, there was a change in stimulators. Prior to 2 years ago, pretty much stimulators were used to electronically block pain signals going to the brain. And essentially that's how these work. But what was different 2 years ago is we were using stimulation in a way that we would, instead of having people perceive pain, you'd give them a tingling sensation. So you'd kind of remove the painful sensation, but they still had a tingling, sort of like a TENS unit.
Are we talking about back pain? Are we talking about neck and back pain?
Either one. Sciatica, pain down the arms, exactly.
All right, so you were doing an implantable device.
Correct.
That delivers electronic stimulation to the spine.
Correct.
Confuses the
brain
into not feeling the pain.
Exactly.
Okay.
Well, pain is really perceived in the brain. So, it's not like when you have sciatica, it's not that there's pain inherent in the leg, okay? There's basically receptors in the leg. The signals can go to the spinal cord. From the spinal cord, they go to the thalamus, and then they go to the brain, and the brain interprets that signal and says, you've got pain. So you can use medications at multiple different points. You can use anti-inflammatories to desensitize the receptors. You can use drugs like gabapentin or Lyrica to quiet down the nerves. You can use narcotics to decrease the signaling through the spine.
So these narcotics, so I understand this correctly,
right?
They're working on giving a different signal to the brain.
They work in the spinal cord to turn off the signals. By and large, most information that your body senses, the brain doesn't ever pay any attention to it. So, for instance, how much pressure is your shoe applying to your foot? Well, you don't need to know that. So, unless it starts bothering you, and then the signal gets ramped up. So most of the time, most signals are shut off. And what narcotics do is they shut off more of the signals. Mm-hmm. So that's basically how they work. So if you have sciatica and I give you a shot of morphine or something, you say, hey, my pain's gone. Really, the only thing that's happened is the perception by the brain has been changed now, okay?
All right,
so
interesting.
You can use drugs at multiple places. All drugs have side effects. Or you can use electrical stimulation to basically change that signal to the brain.
And without the side effects.
Without the side effects, precisely.
And does it work?
Oh, it works.
Because you've done a lot of these implantable devices over the years.
Works fabulously well, right. So the old stimulation that we had, we would exchange pain for a new stimulation, which was tingling, okay? But many people didn't like the tingling either. So a lot of times, you go, well, I got this great therapy, you try it. And that's the nice thing with these, you get to try them first for about a week or so, see if it does for you what you want it to do. If it does, great. If it doesn't, then you just pull out the wires, there's no incision, nothing implanted. If it does work well for you, then you go ahead and go to implant.
Okay.
So now the new technology allows us to block the pain without giving you a tingly sensation. So these are called paresthesia free. So, and there's a couple different models that have come out. One, the initial one that came out was a super high frequency. It's kind of like, how dogs are, we can't hear things that dogs can hear.
Yes.
It's a high frequency. So this is a high frequency. Your spinal cord per se, your brain doesn't really comprehend that there's something going on. But over about 3, 4, 5 days, the brain starts to turn off the pain signals. So the newer stimulation, basically what we're doing is we're using stimulation to just replace the pain signal.
So it's a higher frequency than before.
Well, there's one that's higher frequency. The other one that we now use, or I think is one of the best, there is one called burst. And what that is a very rapid firing of about 5 impulses, and then a quiet period, then a rapid 5 impulses. So the advantage of that is that really is much more like how the nerves actually fire. Okay, so nerves normally don't just send signals bing, bing, bing. They send signals when something's going on. They send a lot of signals. When it's quiet, they're not sending many signals. So old stimulators would always stimulate bing, bing, bing. The new ones now will stimulate either at super high frequency, your brain doesn't perceive it, or burst stimulation, which gives a pattern and then shuts off, pattern and shuts off, which mostly mimics what the nerves actually do. So the advantage of that is we're able to block the pain signals without actually without giving you a tingly sensation. So
Are you now the people that are in the old implantable devices you were doing before with electronic stimulation? Are you replacing with these newer models, or do you encourage that?
Correct. A number of them are changing because this upgrading technology, the upgrading technology, not only is it better in terms of that they don't have to feel the sensation, but also burst stimulation seems to activate another pathway in the brain that actually helps with the emotional component of pain. So when you have pain, and if everybody's had pain at some point.
Yes.
So when you have pain again, there's always a tie-in to what that pain meaning might be, particularly if it was a disabling type pain. So if you had pain in your leg and you couldn't work and whatever, and now you get sciatica again and you're thinking, oh my God, I'm not going to be able to work, and
You start getting negative or worried.
Precisely.
Okay.
So this new burst stimulation seems to work on this, what's called the medial pathway in the brain, and that actually helps with the emotional affect.
Really?
So it actually decreases, helps to some extent with some depression and whatnot.
So less depression. So in the study, they found people were less depressed about the potential of future pain.
Well, less depressed, less suffering, less catastrophizing. People that if they have pain and you think, oh my God, it's the end of the world, those people tend not to do well with just traditional stimulation, because while you can block their pain, their sense, and particularly when they used to always have a sensation, they don't, oh my God, if I don't have the stimulation, I'm going to have a problem. So now it's just blocked out, and they don't have that, that emotional component to it. So we call it sort of the suffering component. Actually, it's also helped not just the intensity of the pain that they feel.
Now, what kind of back problems? So people are watching this. What kind of back problems is this new burst stimulation good for?
Well, burst stimulation, traditional stimulation was particularly good for leg pain, not particularly good for back. The new stimulators, the one at real high frequency or the burst stimulation, those actually are about 80% effective for just low back pain as well as pain down the legs. These also can be used for pain in the head, pain down the arms, used for migraines. The electrodes actually can be placed. We have a number of patients, we have 2 patients, 3 patients who have headaches from the occipital nerve, comes up the back of their head. And we can place these over that nerve, stimulate that, and block those migraine headaches. So we've had a number of different patients. One gal in particular, she had surgery on her wrist. I think even three surgeries, and she had burning pain going down her arm. So we actually put in a spinal cord stimulator, which gave her excellent relief, and she'd had it for like 15, 16 years. And when this new technology came along, and particularly because her electrode actually had worn out, it had been in so long, replaced the electrode, put in the new technology. So she loves it so much more because now she doesn't have to feel the tingling in her arm, and she still gets this same pain relief. So she finds that actually she's far more functional, because she used to always worry about, is it tingling, not tingling? Is the tingling too strong or not too strong? So it's been a huge advantage for her because she doesn't have sort of an annoyance, be like if you had to itch all the time, you might go, well, I'm glad I don't have pain, but I got to itch here. Well, if you could just get rid of that, that would be so much better for you. So, we've had a number of patients too who've had, one gal in particular had a hip replacement and had horrible pain. They looked at trying to replace the hip or do something else. Amazingly, the hip actually, when they did it, her pelvic bone had kind of fractured on the pelvic side of it. And they were saying, well, there's nothing we can do. Your bones are too thin. Put in a stimulator. This gal now can walk.
So she found you as like a second opinion kind of thing?
Absolutely. Well, she's coming because
somebody
she's
told her
having
Dr.
pain.
Reinhart needs to look at you, right?
Well, we get that
how it
sometimes.
happens?
We get that sometimes. Yeah,
Okay.
sure. But
If I was in pain, I'd go see you.
well, thanks.
Okay.
Okay.
So she goes to you. You clearly see, which they were telling her not much can be done.
Oh, absolutely,
Right?
absolutely.
Okay.
They told her there was nothing else to do. They
Other than
couldn't
more pain
rebuild
meds.
her hip. Give her pain meds. She was on Norco about 6 a day, and really not doing well.
Is that
Couldn't
bad
sleep
stuff?
well at night. Well, amazingly, America consumes 99% of all the Vicodin in the world. I mean, in the entire world.
Is that right?
The United States consumes 99%. So, there is a huge problem with opioids in this country. And fortunately, this is a kind of technology that can really help to give people pain relief that they need without having to use the narcotics.
So I interrupted you, but that woman with the terrible hip replacement pain.
Right.
So she gets the new stimulation.
Right.
And what happens?
So now she can walk as far as she wants. She doesn't have problems. She used to have to sit down everywhere she'd go. Half the time she was limping. If she was particularly bad, she'd have to go around in a wheelchair. And but now she can walk on her own. She can walk
That's a
as far
big
as she
deal.
wants.
So she's almost pain-free?
Oh, it's tremendous difference.
And
with
no
her pain.
drugs.
And no drugs, absolutely, yeah. So
Because all the people on drugs, none of them want to be on drugs, right?
well, I would say that's true.
it works. They're on them because it works.
Because it
So
it gives
this
them relief.
electronic stimulation, is this the future of pain management, do you think?
Oh, I think it is.
It'll just
And
become more sophisticated over time?
It will. And the other big advance that we have is another kind of therapy called DRG therapy. And DRG therapy basically stimulating like single nerves that come into the spine from specific areas. So again, for this hip lady, we've got a lady who had knee surgery, had pain in her knee. This is really a frequent problem, and a lot of patients, don't know there's anything that can be done. So they have a hip or knee, they go back, the surgeon says everything looks great, they say, but it still hurts. We used to look and see, was there loosening or whatnot? And a lot of times there was no loosening, it was just the healing, but they still were having a significant pain. Well, they didn't necessarily need to have their whole leg treated, but they did need to have the specific nerve that went to that area treated. So with DRG stimulation, which stands for dorsal root ganglion stimulation, those are the sensory fibers that come into the nerve. And with this, it's a very tiny wire. We just put it out over that nerve, stimulate that, and basically can block pain specifically to the foot, to the knee, to the hip. We have one gal, she has back pain because she's got some spinal stenosis, pain down her leg. Spinal cord stimulator was somewhat helpful with her, but she still complained of her vaginal pain. We placed a dorsal root ganglion or DRG stimulator in at the first lumbar level, and she had about 80% relief of her vaginal pain. So it's these new therapies, again, what we're doing is telling the brain, we're just changing that signaling.
Wow.
And telling the brain, hey, the pain isn't there. Now, obviously if you have some problem with weakness in your leg or something, to just cover the pain isn't effective. So again, we look at the whole picture with the patient. If the spine's stable, then it may be appropriate to put in a stimulator. If their spine is unstable, then it wouldn't be appropriate to use
In the
that.
desert, you're working with an older population.
Right.
Much different maybe than the guys in LA?
Oh yeah, yeah.
Some of your colleagues
Sure.
there.
Well,
and how is it different?
Well, they call Palm Springs, God's waiting room. So, a lot of the patients, can't have surgery, maybe too unhealthy or may have some problems that limit that. So these are therapies that can block the pain. We're not necessarily changing anything about structure, but actually just turning off the pain signal to the brain and allowing them to have a much more normal life.
So would you say there's maybe hundreds or maybe even thousands of people within an hour of your practice that are taking meds, managing their pain, when they could get off those meds, get a stimulator, and probably get better results?
Probably tens of thousands.
Tens of thousands.
Literally. Yeah.
And so why aren't they doing it? Are they just afraid of the word surgery? Are they're not being offered this?
I think a lot of times, it's sort of like they've come to believe, well, this is all there is, right? I mean, their doctor might say, well, there's nothing can be done for you. And so a lot of them are just not aware. So fortunately, hopefully they'll watch the program and see
because it
this.
seems like people in pain with their Googling research and watching programs, it seems like they would know about these electronic stimulators. Like I feel like I'm missing a piece here. Why aren't more people getting stimulation even offered to them? And you say that this one, you could do a trial. You could try it for a week.
Well, with all
is that
of
true?
these, with all these, you try them for a week. So the beauty of this is you trial it for a week, and then even if you go to implant, if for somewhere down the road there's a brilliant new breakthrough that works 100% of the time, then this is basically removable. So nothing's ever cut out of the spine. We don't structurally change your spine. So the nice thing is you get to try it first, if you like it.
Yeah.
If you go to implant, great. If something else happens down the road and it has to come out, it's always reversible.
How soon will they know, by the way?
Structurally.
Are there any miracle stories where you did it and they're going, I already feel better?
Oh, absolutely. Well, yeah. So usually with this new stimulation, again, you don't feel it. Like when you used to turn on the tonic, they'd say, okay, I feel that, yeah, it feels good or it doesn't.
Like the tingling.
And they do it right away, correct.
Okay.
Correct. So now with this one, since you don't feel anything, it takes usually about 3 days or so before the brain starts to modulate the signaling to the brain. And so usually from day 3 to day 7. So typically after that, we have patients frequently who will have, 70, 80% relief. Now, our goal is at least 50% relief, okay? We're not looking for it. But if they don't get, if they're kind of 40%, well, kind of helps. Those probably aren't people who would really benefit from this therapy, okay? So it's getting the right patients. Our implant rate's about 85, 90%, which means we're probably a little too selective. Medicare wants at least a 50% rate. So about half the people you trial go to implant. That's what Medicare wants, meaning that you're not just, putting a bunch of wires in people and saying, hey, you feel better. You want to actually evaluate the patients and see, is this something that's likely to help them? And so we do a very good job, I think, of sorting those people out.
So if somebody's watching this and they're under medication, maybe 7 months, 8 months, and it's taking care of their pain, right? Their leg pain,
sure.
whatever.
Okay.
Are these people ideal candidates? And they have all this, side effects associated with the medications.
Well, that's the thing, is they may feel
so are
like...
they ideal candidates for this?
Absolutely.
Really?
Absolutely. So, and if they, they might feel like their medication's handling it, but, typically with narcotics, you're going to have constipation, trouble thinking. Usually constipation in our population is a huge problem. So, they may feel like, well, I can get by, whatever. But, it's like finding out how much better your quality of life can be, because those medications are going to cause problems for you. They may not be things that I would say probably they're things you become more accustomed to, and you say, well, I just have to put up with that because I'm taking these pain meds and I'd rather have the pain meds and be constipated. But in point of fact, you could have a stimulator, get rid of your pain, not need the narcotics, and actually your life would be considerably better.
So Medicare, Medicaid, insurances all cover this?
All insurances cover this, absolutely.
Now, do they need a referral from their primary care physician to see you?
Do not. You can come directly to our office.
So they can call directly to you?
Absolutely.
And it's covered by insurance?
Absolutely.
Now, there's always co-pays involved in some of these. Are you less expensive with co-pays than a hospital?
Well, compared, hospitals now, there's been a huge change in medicine. And hospitals are now buying doctors, so to speak. And so if you're working for the hospital is entitled to charge what's called a facility fee. So when you go to see that doctor, you get not only the doctor's charge, but you're going to get a charge from the hospital, which may be, 3, 4, 5 times what the doctor's charge is. So he may charge you $100, but the facility fee will be $100 or $400 or so.
So more cash out of pocket, like
far more
copay
money,
kind of money?
particularly when you have copays.
Like a couple $100 more
Probably even more than that. So,
Really?
So, and then typically, doctors that utilize the hospital or owned by the hospital will use hospital laboratory services, imaging services. Those may be as much as 10 times what it is out in the independent sector. So it's considerably cheaper, particularly if you're a person who's got a big copay. Medicare has fixed out of pocket for the patients. Doesn't help the national deficit. Their children will be paying those bills. But for considerably less money, you can get at least as good a care from an independent physician as you can from a physician.
Now, I have visited
by the hospital.
your center. It's very large, lots of people there. It's like a mini hospital. And you have your own operating rooms there. And you're still doing everything under like a scope?
We do.
Everything's
done with a fluoroscope, which is like video X-ray, and that makes sure that everything's safe. We provide all the services. In fact, our surgical center just was inspected by the state and had a zero deficiency, which is almost unheard of. So everything at the surgical center is state of the art. It is it's as good as going to the hospital, if not better in many ways.
Okay, now so then what's your take? If so many people, hundreds of thousands of people, that are currently taking a lot of medications, more than 7 months, and dealing with those side effects, that their pain could be taken care of with a natural, no drug approach with electronic stimulation, confusing the signal of their brain. Why aren't they all doing it? I mean, what's your take? I asked you earlier, maybe is it just the fear of surgery? What is it? Because if they get to try it, why not?
Well, and this is done with actually just local anesthetic or very minimal sedation.
Is it because they don't believe it?
No, I think they just are unaware. I think they're just unaware, and they're just used to somebody saying, well, that's all you can do. I mean, I get that probably 4 times a week. Well, I was told nothing could be done. So there are things.
Really?
Yeah. I mean, there are more options now than ever before for dealing with pain. And I think, I've been saying that for the last 20 years. There was more options. Now there's even better options. So the opportunity to get rid of pain without having to use narcotic medications is really getting much, much better.
What's the downtime like when it's done? And we are short on time, and I know you brought a couple of them here, but what's the downtime? How long does the procedure take you to do?
Yeah, the procedure itself, so the trial actually in terms of surgical time is maybe a half hour, 45 minutes. Downtime is really zero. We want you up, we want you moving, we want you doing activities you do. We don't want a lot of, wild acrobatics or something.
All right.
But we do want you to be doing things. So you find out, hey, does this really do for me what I want to do?
They start with a trial. For people just tuning in, we're talking about electronic stimulation. So they go in, they start with a trial.
Correct.
Like they wear it on their, that's one of them.
Correct. So actually, these are the implanted devices. So just this tiny little wire. I don't know if you can see that there.
Okay, it's so small you can't even see it.
Little,
we can see it.
Tiny little wire is placed much like an epidural, except instead of injecting medicine, we just slide these wires in. And then we will use an external battery, which just is taped on their back. And they have an iPod. They're given actually an iPod to control it. So it's a wireless Bluetooth. And they try it for about a week. Again, as I said, it takes about 3 days to start.
And they come back, and what do they say?
They feel much better.
They say
remarkably better. That's right. That's right. Well, and again, the role here, or the key here, is to make sure for them it does for them what they want it to do.
So you walk in the room, and you see their faces sometimes lit up.
Absolutely.
Like, oh my goodness, this is
absolutely.
great.
They're ecstatic. And then they're upset.
Really?
And then they're upset because you have to take out the temporary wire and at least let the tissues heal for a few weeks. And most of them come in and say, I don't want you to take out the wire, but you got to take out the wire.
You have to do it.
Yeah. And then you'll come back and implant another system.
And so I understand this for people just tuning in. So narcotics work by?
Just changing the signal going to the brain. So
and you can take electronic stimulation does the same thing.
Same thing, but no narcotics. And a lot of other drugs like gabapentin or Lyrica, which suppress nerve firing, those make you tired and dopey. So with one of these stimulators, if you can get that pain relief without being made tired, well, your life is much more better. You're much more plugged into what's going on.
So is this an exciting time for you?
It's a great time. And actually the last few years have been wonderful, and I think there's going to be many more advances along these same kind of lines.
I mean, look, I guess anybody watching this in pain, they've got to be a little skeptical, right? Somewhat skeptical, because they've chose drug therapy over this, or maybe it wasn't offered. Yeah, I mean, if everybody believed what you're saying today, you couldn't handle the business. You couldn't handle the patient load. I mean, it's the truth.
That would be great for the patients, right?
I know you have a big parking lot over there, but there wouldn't be enough parking.
Yeah, but the point is to give the best therapy to the patient. So, that would be great. If they all come in, great. We'll figure out a way to make it happen for them. Maybe the wait will be 4 hours instead of 3.
Is that right? That's right. So they could get in the same day.
Same day or the next day, it's going to be fast. So if they just say, hey, I'm having horrible pain, we'll get them in.
Now, you mentioned somebody with their hand pain or arm pain. Is there a particular area of pain where this is like ideal for, like sciatica, it's excellent for? Is there a particular...
Sciatica or cervical radiculopathy, anything where pain's going down the arm, also back pain as an individual separate item. So any of those things, the burst stimulation works well for, again, the radiculopathies, which is pain radiating down the arm, headache pain. The DRG therapy is particularly good if you have pain in a very select area like your knee, your foot. Your foot in particular is much better covered with DRG. So, basically the great thing is we have a wide variety of treatments.
We really have about a minute left, but if somebody calls your office, do they just say, look, I want a consultation about this stimulation device?
Sure.
And then they see you, insurance covers it.
Sure.
And they can try it for a couple of weeks or a week.
Correct. Well, and again, like with all patients, we're going to evaluate the patient, see if that's an appropriate therapy for them.
So you're going to look under scope or under imaging, and you will know from experience where, with a high predictability, you think this will work.
I would say that we're very good about getting the right diagnosis before we start the treatment. So we want to make sure that we're doing the right thing for the patient.
It's still a mind blower to me that if it's available, covered by insurance, you get a 1-week trial, you get a chance to get off your medication. Why not?
It
seems like everybody would do this or try it.
It often amazes me how many people just become sort of complacent about it. It's sort of like, this is my lot in life. And again, that kind of goes along with the psychological downer of it, where bursts can be helpful, but they feel like, well, no, I'm used to these narcotics and whatever. But I think a lot of them, you can see from the outside that they have a lot of other problems related to taking that medicine.
Okay.
And so, they would benefit tremendously from
Now, I don't know a thing about narcotics, but this is a group, obviously, if you're in pain, there's a depression that goes with it. The narcotics maybe are numbing their ambition, so they're not willing to try new things possibly.
Well,
that's
possibly true, absolutely.
So maybe a spouse needs to say, you should, look into the stimulation.
About 70% of people with pain end up depressed, and about 70% of people who are depressed have pain complaints. So there's a huge overlap. And again, I think that's one advantage of the burst stimulation, that we're actually dealing with the affective part, the emotional part, as well as the pain part. So it's actually, I think probably, again, improvements in technology, improvements in understanding are going to make pain control much, much better.
Now, I know you have a busy practice and a big place. Do they get to see you if they want to?
Yeah, I see every new patient that comes in.
Is that right?
Yeah, and I see him on
People
follow.
like you, by
I'm
the
busy.
way.
Oh, that's nice.
I don't think I've ever sent anybody, friend of mine, to you for pain, but it seems like everybody that meets you, they'll say, yeah, I mean, he's so nice, great listener.
Yeah, but you don't have any friends, Randy.
That's right. Well, because of the show. It's hard to, because I interrupt so much, according to you.
Sorry about
So
that.
I'm trying not to interrupt today.
Do you want to go back to that again?
No, that's okay. Listen, we are out of time, and I want to thank you for coming on the show. Always a pleasure. They could go to your website and make an appointment there, or call directly. They don't need a referral to see you.
Don't need a referral.
And ask, tell them on the phone.
Tell them on the phone.
I want to see if I'm a candidate for electronic stimulation.
For this, or we'll evaluate whatever else they may be.
Because there's a list of things, by the way, and we're going to do a second interview about some of the other new things you're doing for the back. So implantable devices. So thanks so much.
Great. Thank you.
You've been watching The Wellness Hour. I'm Randy Alvarez. For now, I wish you good health.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.